I'm doing a case. So what I'm doing is essentially doing pretty much what we all do in the operating room. Anesthesia record on a pen and paper, and the charge ticket. And what we're doing is, this is the anesthesia record. It can be any anesthesia record, whatever you're using, without changing the format. And let's pretend I'm doing a case. That's a quick case, by the way. And start time, stop time, diagnosis, acute, typical handwriting of an anesthesiologist or a CRNA, you know. And the surgeon, who's your favorite surgeon?
Doctor bleeds a lot.
Oh, bleeds a lot. Bleeds a lot. Okay. Acute, lap epi, and I'm going to pick from any of the OR schedule, any one of the cases from the OR schedule, 200350, and 10:17:10, 1300 start time, 1340 stop time, and fill out the charge ticket because it's important that you make money. 200350, 10:17 to 10. I'm the anesthesiologist. Don't worry about the patient's name because this pen has the capability to talk to the hospital's electronic medical records and grab the demographics automatically. Diagnosis: acute appendicitis. Surgeon bleeds a lot. Procedure: lap epi. 7:30 start time. 8:30 stop time. General anesthesia. ASA 2. Antibiotic delivered. Euthermia. Case is done. What I'm gonna do.
But again, we can create our own form letter.
We can use whatever form that you're using right now. Okay. So this is just for demo purposes. This is just a regular A4 paper, and it can be any form that you're using. You don't have to change. All we're asking you is to use this pen. As simple as that one. And end of the case in PACU, drop the paperwork off, and I'm gonna drop the pen, and that's it. You go back to the next case. You're seeing your pre-op while this is happening. This case is being transferred already to your billing computers, your back office, wherever it is. And now, give me 2 minutes if you want to pause that.
So
we can keep going.
We'd like to ask you a couple of questions. Sure. So the pen itself, you were using to write on a real paper, which we have as a real paper backup.
That's correct.
The pen was not transmitting to a computer or a base station, but it was actually recording what you were writing into the pen.
That's correct. So, and to answer your question, yes and no. The pen, when we dock it, there's transferred information, but there is technology which can be transferring real time as you're writing it, connecting to your iPhone or to your phone in a Bluetooth technology. But the problem with that is the hospital doesn't have good cell phone signal. That's the reason we want to depend on a signal, depend on technology which is guaranteed, which should be an internet or a Wi-Fi, for example, in the hospital. If it has a very good cell phone signal in your hospital, you can be doing real time with your cell phone because the pen connects to your Bluetooth to your phone and then goes.
If there is a compliance problem, if perhaps there is overlap for one or another provider, how does the system help with that sort of error finding?
This one, for example, one anesthesiologist supervising 3 rooms, for example, and then the board runner comes to you and goes, you know what, Phil, why don't you go do an endo, I'll cover your rooms. Classic thing that happens every day in an operating room. You go start doing a case and I don't go sign into your rooms. Now you're doing cases, supervising 3 rooms and doing a case on your own. It's a concurrency violation. You'll get a real-time page in an email saying that this is what's happening and you guys need to go sign it.
Now, will that only happen once I've docked my pen?
That happens once you dock your pen, yes, because this can be corrected at the time because it can go back and change the time.
So we're going to find out about that problem the hour or so that the error is generated, and not the next day or the following Monday or Tuesday when the billing company discovers the compliance.
That's correct. And then also the stop time. Missing stop time, for example, missing start time, missing diagnosis, missing procedure, missing ASA status, missing type of anesthesia, missing AQI data, whatever it is, which is important for not just for billing but also for compliance issues. You get real-time page and email. And Raj is going to Raj, you want to show me the iPhone? So whatever smartphone it is, you get a real-time page and an email. And the example is this. This is from Allegro Consulting. This is the parent company. Stop time not available for this medical record. stop are not available, PQRA not available for this medical record. So you can go correct it then and there.
I'm in a trauma case and I had blood on my pen, on my hand, and now it's on my pen. How can I clean this device so it's not an infection hazard?
You can use your regular bleach that you use, the bleach wipes that you use, and wipe it off.
When the stylus runs out of ink, do I have to throw this one away?
No, you can replace it.
We can replace it. Every pen gets with 4 spare refills, and we've been using this since last October. The same pen, and our developers have been testing it, heartily. So that's where it is.
And the key thing with post-op PACU, for example, the sign-out. Right now, Medicare is mandating that you look at 6 parameters to sign out a patient. I don't know if you guys have implemented this already, and you'll be called for a sign-out. Respiratory status, pain status, cardiovascular function. These can be checked off, and same thing can be digitized, which you'll be seeing in a minute. And so, go ahead.
Does this change how we do post-op checks as well?
It can, if anything, it's going to make your life easy. It's going to make you look good in front of the administration, which I'll show you in a minute. And one person can do 100 post-ops, for example, without even flipping the patient's chart and exactly knowing what the patient had done yesterday and actually accessing the anesthesia record without even flipping the patient's chart.
Novel technology from ASA 2010.
Here it is. It's up.
This is the acute appendicitis. Whatever I wrote is on already in the back of the billing computer. Not only is it on the scan form, it's actually digitized and typed up already and pre-populated into the billing computers. Same stuff.
Typically, how do providers protect this data integrity in case of power loss on site?
The pen holds all the information, so up to 1,200 pages is what the pen holds. So there's no loss of data.
But isn't there also a written record?
As a backup, always. So this is your post-op log. This is the patient we just did.
Phil was post-call yesterday, so he wasn't even in the hospital.
And he doesn't know
No
anything
coffee.
about the patient. All the patient information is already there. Anesthesiologist, type of anesthesia, ASA status, PQRA compliant or not, data surgery,
Sample.
patient age, everything is already there. He knows nothing about the patient, is already there. Jordan?
Yes, you can show the bill.
Okay. And then, if he has questions about the case, he can look at the billing ticket without logging it or asking anyone. And go back to the survey form, which is your post-op. Same thing. Anesthesia.
You can also actually look at the anesthesia record, but it's taking a long time to download. So
Okay. I can quickly check if you want me.
No, I don't.
Okay. All right. And then do the post-op.
So I would ask the patient the sample questions. Did we meet with you ahead of time and answer all your questions? Yes, says the patient. Were you comfortable and unaware throughout your procedure? Yes. Did you have any problems? Yes, I had some nausea. My pain scale on 1 to 10 was, of course, a 10. And other?
You can just hit continue and you'll see.
Continue.
These are the AQI 26 indices that ASA is mandating. Is looking for. We already have it. Dental trauma, unexpected intubation, unexpected ICU stay, difficult IV access. Everything is already there.
So this tracks QA data
Absolutely,
as well.
100%. Go ahead.
without changing anything.
Without changing your workflow.
We're going to answer no to critical events and continue.
And the patient satisfaction survey, which is key for a group to maintain their contracts. When you go back to the hospital administration and say, my patient satisfaction survey is 100%, it's hard for them to, and this is all on data, it's hard for them to replace a group and maintain your contracts, not to mention get your stipend and maintain your stipend and ask for more stipend. And
Overall, how would you grade your anesthetic experience? She says it's a 4.
Save.
We'll save that.
That is done. Now comes the key part. Now that we have all your post-ops, I can pull out all your case logs. For example, I can look at the APIs. For the month of September, just month of September, all lab APIs, different anesthesiologists, same surgeon, same type of anesthesia, same duration of anesthesia, same ASA status, different post-op nausea and vomiting, different pain, different complications, different patient satisfaction survey. Go back to the more records, I can look at the turnover times between the ORs and see how efficient you are. Days of activity, the cases, number of cases done, hours utilized in the operating room. Go back.
And all this is Mocha, so eventually it will help you with that as well.
Absolutely.
And you you get to see.
Number 7 to 3 is when anesthesia groups spend most of the money. 7 to 5 is staffing CRNAs, for example. Over the time, you're paying overtime. You know what you did and how efficient you were in managing your OR without changing the workflow.
Adam's going to love that.
So what we can do for you guys is different pie graph, chart graph, line graph, doesn't matter. And what we can do for you is come and do a demo, actually do a pilot for a month, because you're not changing anything. All you're doing is grabbing the pen and do a pilot with you. And sorry, go ahead.
Indeed. Okay.